This is the post-procedure. And then you're going to see some still images of all the wax, debris, hairs, keratin removed, and that's everything there laid bare on the tissue. So whilst we're doing the procedure, we're getting chunks out. We place that on the tissue before we go back into the ear to get some more wax out. And I thought it was important to show that because it is quite a long video. It's a bit of an epic one. And I just thought it's useful for you guys to see that, just to keep your attention span. Because I know some people don't like when the videos are too long, but as I said, this is a really, really complex procedure. The patient actually attended today, and it's their son that brought the patient, and the son was very worried for the last 6 to 9 months that their father's hearing was significantly deteriorating. They weren't sure if it was wax related or if it was underlying hearing loss. So they booked themselves in for a full consultation, and as soon as I examined the ears, I notified the patient that they've got a really severe wax impaction, and the left ear, so the ear that we're working on at the moment, was the worst of the two. And you can see the patient's got a lot of hairs just at the entrance. That's more tragal hairs as opposed to hairs within the ear canal itself. So the tragus is the little flap of cartilage just on the outer part, just so it's not in your ear canal, it's the bit on the outside. Quite often people can get tragal piercings. So it's a little, you can actually use your finger and just flap that tragus, and it'll flap backwards and forwards. There was a few hairs inside the ear canal. So this is the first bend of the ear. So you can see there's a few hairs there. So the tragal hairs weren't affecting me in any way, although I can appreciate if you're watching and they can obscure your view a bit, but we don't want to remove hairs unnecessarily. It wasn't causing me an issue. I was still able to remove all of this wax. Started off with suction. It was just too embedded. There's loads of skin adhesions, especially against the back canal wall. So the back part of the ear canal, we call that the posterior canal wall, and we're working quite laterally, so we call it the posterior lateral canal wall. So that's the back part of the ear canal near the entrance. You can see here what I'm trying to do is use the suction probe to just trying to lift this, peel this, separate it from the canal wall. But it's really, really strongly adhered. So I'm going to use a combination of instruments, hooks, scoops. I'm going to use the forceps quite a lot in this procedure because of the hairs. I was trying to avoid putting oil in at this point, just because when there's loads of hairs, matted hairs, oil can be counterproductive at times. So I'm just using a Jobson horn, otherwise known as a curette. It's kind of a hollow spoon. I'm just trying to get around the periphery of this wax and keratin plug that's also matted with loads of hairs. Trying to, again, separate it from the canal wall. Whilst you're watching that, I'm just going to go through some questions. One of the first questions, I think, from yesterday's video is whether I'm aware of Mondini dysplasia. Yes, never come across anyone with that, but we did study at university. It's a hereditary congenital condition where the organ of hearing, the cochlea, is not fully formed. The human organ of hearing called the cochlea, it looks like a snail, and it's got typically not typically, it should have 2.5 turns. In cases of Mondini dysplasia, the cochlea is not fully formed and it's 1.5 turns. So yes, I have come across it at university. Have I met anyone with it? Personally, no, I haven't. Some of the other questions were, if you perform the Valsalva, so if you close your mouth, pinch your nose and blow too hard, is there a chance of perforating your eardrum? Now, I would say yes. It's very rare, very unlikely, but if you overexert pressure, so I mean, sometimes divers, when they dive in, they can perforate the eardrum. So the eardrum is very robust, probably a lot more, it's got a lot more rigidity than most people believe it has. But yeah, if you overexert pressure and you overperform the Valsalva, there is a small chance can perforate the eardrum. Now, as audiologists and also ENT doctors, I know we sometimes ask the patients to perform the Valsalva as part of our diagnosis and treatment. So it is, I would say it's pretty safe, but at the same time, yes, be aware there is a risk. Don't overdo it. I'll just come back to the video for a moment. Just use an ear hook there, and I went underneath the plug of wax at the base of the ear canal, rotated the hook, and now I'm going to the top and I'm doing exactly the same. I'm rotating it clockwise, trying to get some purchase. and it's slowly coming out. So every time I'm coming out with an instrument, I am getting some wax out, and every time I did come out, the patient and the son were looking over at the tissue, and they were quite surprised by how much they were seeing. And even by this stage, they were quite shocked because, well, that's a lot of wax on the tissue. And I had to explain to the patient and the son, well, that's just the tip of the iceberg. There's so much more to come out. So just using the forceps now, you can see I'm just wriggling that, trying to detach it, separate it from the canal wall. Because there's a few hairs there, I was able to get some good purchase and grip. So just go back to some of the other questions. Some people wanted to know my fees. Now that's all on my website, www.thehairclinic.co.uk. So for an earwax removal appointment, we charge a default fee of £65. That is to cover the appointment, and it also includes the examination of both ears and the removal of wax from one ear, if of course you do have wax. A lot of the time people come in and they don't have wax, so we still charge for the appointment. Of course we try to decipher and diagnose what's causing the patient's symptoms, and then if you've got wax in both ears, it's an additional £30. So the minimum you pay is £65, the maximum you pay is £95. My prices are going to go up soon. Looking at what everyone else is charging in the UK, and comparatively, I should be charging a lot more in comparison. I've kind of restrained for a while, but I think I'm going to have to do that sooner rather than later. There were some questions about hearing aid prices. Again, guys, look on my website, www.thehairclinic.co.uk. I've got many hearing aids listed on my website, and they all vary in price, but just to give you some guidance, the entry-level hearing aid, so this is single per hearing aid, entry-level hearing aids start off around, I think, £650, £700, and the most expensive hearing aids can go up to £1,800 per ear. And when you buy hearing aids, you're not just buying the product, you're buying the audiologist and the expertise. You can buy the best hearing aid in the world, but if it's not optimally programmed appropriately for you, then you're going to not get the benefit you should. And contrary to that, I used to work for the National Health Service many years ago when I first graduated. Obviously, the hearing aids are decent quality, they're good technology level, but if you could have someone who has NHS hearing aids that are programmed fantastically well in comparison to someone who's got the very latest private hearing aids that are not programmed as well, and you're going to get more benefit from the NHS hearing aids. So whenever if you're thinking of purchasing hearing aids, guys, it's not just, when you're looking at the price, think about it's not just a device. The analogy I give to a lot of my patients is that if you're having a dental implant, you can buy the best grade quality of dental implant available, but if your dentist is not as good as another dentist and they don't perform the procedure as well as a more experienced, skilled dentist can, then that's what you're paying for. You're paying for the expertise. If you're having a new kitchen fitted, you can buy all the latest mod-cons, worktops, tilings, flooring, but if it's not fitted well, it's kind of a waste of money. So that's just a rough guide. I think some of the other questions were relating to, I think there's one about the colour of earwax in dogs. Again, don't really want to comment on that because I don't treat dogs, and so. But I can only imagine earwax is the same for all creature species that have it. It's very common in mammals, is earwax, and yes, as the wax oxidizes, it gets darker. So I think the question's relating to the colour of the earwax in dogs. There was another question about discharge from the ears and whether they should go back to the doctors. Well, yes, you need to go back to the doctors. So some of these questions, they're kind of, I don't want you to rely on me to answer before you seek help. I'm just trying to give general advice. I don't want to give individual specific treatment plans, but if you're getting discharge from your ears and you've got a perforation, please do go to your doctor and get that checked. That's so important that you do. Now, perforations sometimes can spontaneously self-heal. If it does, it can, the period of healing, it depends on the size of the perforation, but I would say minimum 6 weeks, can be up to 12 weeks. That's the normal span. After that, it's very unlikely it's going to self-heal. So just going back to the video, we removed half the wax out. Now this is the more medial plug. You see it's darker, it's been there longer, there's loads of hairs, and again I'm just going at it with the forceps. The patient has got a bit of a bendy, twisty ear canal. Another question was whether I know Craig David. For those of you who don't know who Craig David is a well-known garage R&B star in the UK. I take it as a compliment because once that I sound like him, I certainly don't sing or rap like him. But no, I don't know Craig David. But again, guys, let's focus on the purpose of the channel. We're talking about earwax here, so I just wanted to point that out, but I'm not going to be answering questions like that moving forwards. So some of the other questions was, if you've got dry ears, how do you treat that? So avoid water in your ear, guys. You can use some olive oil, earwax spray or drops. Don't use stuff over in your kitchen if avoidable. Stuff over the counter has been it's medical grade, so it's been tested for safe use in the ear. So the olive oil can help moisturise the skin in the ear and prevent the skin from drying and cracking. If it gets really, really itchy and that's not helping, go to your doctor, your physician, have them to have a look. You may have some otitis externa, which needs treatment. Don't use cotton buds. I think that was the other question. Cotton buds will graze the skin of the ear canal, the epithelial layer of skin. As that skin begins to regrow and heal, that will also cause an itch. Just do avoid that. Another question was whether you can have a blocked ear full of earwax and be unaware of it. Yes, it is possible. Quite often patients come in or they attend with a friend or family member, and whilst they're there, they do ask whether I can have a look, and quite often those individuals do have a lot of wax and they're quite surprised to learn of that. And that's because wax is a benign condition. It doesn't happen overnight, the blockage, and it becomes... if you gradually lose your hearing, sometimes you're not aware of it. It becomes the norm almost. So yes, that can be the case. Another question was whether what we do with the wax. Now, wax, if it's not infected, it can go into general waste. If it's infected, you have to use a clinical waste bag for that. So that has to be disposed of separately. All the instruments I use are single use. We can use them between ears of the same patient, just as long as the patient doesn't have an infection in one ear, because we don't want to cross-contaminate. Another question was, on a hot day when the earwax is, I think, soft and melting, is it a good idea to pinch your nose and suck in? That's completely separate mechanism. So earwax is formed in the outer ear. So your eardrum separates the outer ear from the middle ear. So earwax is on one side of the eardrum, and if you pinch your nose and suck in, that affects the pressure behind the eardrum. So it's two unrelated areas. So the answer to that is of course no. I had a question relating to the use of hydrogen peroxide drops. I typically don't use hydrogen peroxide drops for a couple of reasons. Hydrogen peroxide drops, in my opinion at least, it turns the wax very mushy, almost like mashed potato, which can make it very difficult to remove. In addition, hydrogen peroxide drops is water-based. If you watch my channel a lot, you know that I'm not a big fan of water in the ear. And finally, it's alkaline, the pH, and the ear is slightly acidic. So if you have someone who uses hydrogen peroxide drops for a prolonged period of time, it can cause some irritation in the ear. So I would definitely avoid hydrogen peroxide drops if at all possible. If you do get water in your ears, another question, how do you dry it? So obviously tilt your head to the side, and you can from a distance get a hairdryer. Now, you obviously don't have it on full blast. If you've only got one setting, hold it further away from your ear. You just want a gentle breeze of air going into your ear. If you've got a hairdryer that's got normal room temperature airs, most hairdryers obviously have hot air. The one I've got has got cold, hot, and room temperature. Room temperature is better because if you have it too hot or too cold, it can induce the caloric effect and you can get momentarily dizzy. So yeah, just short, brief, kind of goes with the hairdryer, not too close because you don't want to perforate your eardrum, of course. I think that's the majority of the questions. I'm just going to go back to the video now. So this final plug, you can see how matted it is, and it's really, really hard to vacuum. The patient's got quite a bendy ear, so it's difficult to take access. I can't really use a hook or a scoop that deep in the ear because we're probably going to make contact with the eardrum, the bony part of the ear. It should be very uncomfortable for the patient. So I just squirted some oil in, used the forceps, managed to drag this forwards. But this plug, we've removed a tremendous amount of wax already, and you can see by the opening images just as how much wax was on that tissue. And it was almost the majority of wax, the smaller bits were there. You can see that was as I was removing all this wax, it came out in small pieces. But now you've probably saw 2 big pieces of wax, or 3 even, on the tissue, and this is now going to come out in 2 big blobs, lumps, and then you're going to see one big one from the right ear. So if you stay tuned, you'll also see the right ear. So I've brought this all the way forwards, but it's such a big plug, it's larger than the entrance of the ear. Now, this is where potentially the tragal hairs can slightly obscure my view, just because it's so lateral now, it's so near the entrance, this wax. I'm having to position the endoscope near the tragus, because if I go any further, it's going to touch the wax. Again, I'm just using forceps. I think I'm going to use an ear hook as well, trying to get in and behind, but it's almost pitch black, this wax, so we know it's been there for a long, long time. It's oxidized. Again, I'm just almost dissecting this. Every time I go with the forceps, it's snipping a bit away, it's tearing a bit of wax off the main body, the main core. You can see that's coming forwards a bit. Again, I've just got a purchase and I'm bringing it forwards. So this final piece was a bit firmer as well. It was had a solid core, so that's a big lump there. And again, I got another large piece out there, but it fell into 2 separate pieces as I extracted it. So I've just gone with a hook, and I think this is the big piece. Let's have a look. Yeah, that's the. So for most people, the size of that wax would be the equivalent of removing wax from both ears, but that's just the last piece of wax from this patient's ear, and this is really deep. So we've had to clear all the entrance until we got access to that large last plug, which is right up against the eardrum. Just some dead keratin here. We did get a bit of clarinetting, I think, so I got the majority out before it did. There's some matted skin keratin at the top and also at the bottom. Patient was blown away. He was got quite emotional actually, because it made such a difference. We did also do a hearing test, and they also do have an underlying hearing loss, so this wax obviously wasn't going to help. They do require hearing aids as well. So this is just some, I think it started to clarinet here, so I think I just stopped. Yeah, and I think at that stage it clarineted, so we just left that alone. That's the patient's eardrum. So we're just having a good nosy around just to make sure I've got all the plugs of wax out. So this is the same patient, their right ear. So it's not as blocked, there's a bit more of an opening there, but it does extend all the way to the patient's eardrum. This wax is a bit, you can see it with the hook, it's soft in the core, so the hook just sliced through it like a hot knife through butter. I think someone mentioned that's not a very good analogy. I thought it was a very good one myself, but there you go. So I'm just going to use some forceps, and I'm just going to wriggle this. A typical wax appointment, I allocate half an hour now. Most of the time, I'll say 99% of the time, I'm more or less done in about 10-15 minutes, but occasionally you have these complex cases like this one, and you just don't know which patient it's going to be. So I just always allocate half an hour per patient, even if it takes 5 to 10 minutes. I can then catch up with some of my admin works. When you run a business, it's not just the patients I'm treating. I've got 2 companies that I'm running. And the worst thing is if you've got a complex case and you've only allocated 10 minutes and you've got a backlog then, patients waiting. When you're private, you just want to avoid anyone waiting at all. You want to make your service as streamlined as possible. even these complex ones, I'm getting, say, if it was when I first started this, I wouldn't have probably been able to remove this straight away in one visit when I first started many years ago. And as you get more experienced and skilled, you learn new techniques, you're more confident. Just with anything in life, you're just better at what you do. So even the really complex ones now don't take me as long as they used to. So I might reduce my appointment time slightly, but at the moment it's not causing a problem, so I'll just continue. So what I'm doing here, I'm lifting this off the base of the ear canal, I'm separating it. You can see all this keratin and all these hairs. And once I've lifted it, it then allows me to use the forceps and glide the bottom jaw underneath. You can see there, I've just managed to get underneath. Now, if this was still attached to the canal wall and I glide that bottom jaw, the forceps, underneath, it will obviously make contact with the canal wall. I might graze it, the patient will find it uncomfortable. So hence why I was just using the suction just to lift it. So I've probably got half of this plug out already. At the end, you'll see some close-ups of the large plugs. You see these hairs are almost like straws. They are the tragal hairs, as I said. They're flown in, so when the patient's been trimming their tragal hairs, and they do grow back very, you can see, well, you said he trimmed them recently, and they've really grown back quickly. So just advise the patient to put some cotton wool just at the entrance, not in the ear, just at the entrance, to seal it. So when he does trim his hairs, they don't fly into the ear and mat against the wax. Of course, advise the patient to stop using cotton buds. It's very evident that they have been, and it's pushed it further in. So I want to take this opportunity to thank you guys for some lovely comments. There was a while there I stopped reading the comments because there's so much trolling. You just don't want to expose yourself to it, and it still occurs. But now, just as I'm reading to the comments, obviously answering questions, if there are any those trolls, I just block and delete them now. It's their loss. Now, going back to that, you can just see to the left how dark this wax is. So it's really pitch black. And this is some keratin, dead skin that's adhered itself, enveloped itself around this wax plug. So I'm just using the forceps just to detach this from the canal wall. The skin, the keratin, acts like double-sided sticky tape. Not only does it attach itself to the canal wall, it also adheres itself, envelopes itself around the wax plug, so you're going to have to separate it. So just using the suction probe again, and we're near the entrance, and I'm just lifting this again off the canal wall, and we're on the back part of the ear canal, the posterior canal wall here to the left. I'm trying to mobilise this plug so I can get it out in a big block, which I do manage to do in the end. So I think I use forceps to do that, we shall see. So I'm just making these little movements left and right, just so I detach it. You can see the underlayer of keratin. A few blisters at the bottom of the ear canal, so with dead skin that's adhered to the canal. As you remove it, you can get a bit of blistering. Patient doesn't feel it, it'll just heal itself. So I've more or less mobilised it, but it is lodged in the isthmus, so there's a narrowing near the eardrum. Most people have that about 0.5 centimetre away. The ear canal narrows and widens again, expands, and this is lodged beyond the isthmus. So I'm going to put some oil in. I'm going to use suction, but I think in the end I managed to extract it using forceps. There we are, just using the forceps, just got the top and bottom jaw around the plug of wax, which I wasn't able to do in the patient's left ear because it was fully occluding. Slowly but surely brought this out, and again that's a massive relief for the patient. So I just went in with the suction just to vacuum some oil that was there, and then you're going to see the patient's eardrum, which you saw right at the beginning of the procedure. bit dull, no light reflex, but still mobile. So there's one